Hello, it's great to be able to present my work in this way, and I have to thank the organisers for this opportunity. My name is Mark Pearce and I'm an epidemiologist from Newcastle University in the north of England. I'm going to talk today about our study of radiation exposures from CT scans in childhood and subsequent risk of leukemia and brain tumours. The main results of this study so far were reported in The Lancet in the middle of 2012. In terms of the objective of this talk, I'm going to outline the methodology we used and the findings and interpretation of the UK CT study. I'll also outline what else is happening in this area of research at the moment. Before I go into our methods and findings, I will start with the most important remark I can make, and that's highlighted in red on this slide. CT is very useful, and it's correctly defined as a life-saving technique. It's available worldwide at over 30,000 centres, and this is continuing to increase. And as CT usage becomes more widespread and the technologies change, then the understanding of any risks to patients is crucial to allow better information to be given to patients and parents. In terms of what was known about the risks associated with CT before our study, generally the answer is not enough. However, what we do know is that other low-dose radiation exposures suggest increased cancer risks at the level of several CT scans. For example, in the survivors of the Japanese atomic bombings, in nuclear workers, and in patients with high numbers of X-rays. And what about specific to CT? Well, mostly they're risk projection studies that have extrapolated expected cancer risks based on the likely doses received by patients, so no empirical data. These projections are often limited to certain types of scan, mortality outcomes only, which is a major problem for cancers with good survival rates, and made assumptions regarding modern protocol adjustments that may not have been possible historically. These models using existing risk estimates are very useful, but it's much better if we can complement these models by direct observations of the health effects in relevant populations that we're trying to protect, in this instance children who are having CT scans. And this is where the UK CT scan study comes in. Its formal title is The Long-Term Sequelae of Radiation Exposure Due to Computed Tomography in Childhood and Early Adulthood. And the initial stage of this study, which I'm going to talk about today, was funded by the US National Cancer Institute and the UK Department of Health. So why are we studying young people? Well, with their smaller mass, children tend to receive higher doses to specific organs, but there's great variability of doses, particularly as procedures have not always been adapted for young patients. There are paediatric parameters available, so that exposures can be adjusted, and these depend on age and weight, but historically these parameters were often ignored. Finally, from an epidemiology perspective, children have a longer remaining lifespan in which they can demonstrate radiation-induced effects. This gives us longer follow-up times, which contributes to greater statistical power. A question that often arises due to the American funding that we had is, why did we do this study in the UK? Well, in the UK we have a National Health Service, which I'll often abbreviate to NHS during my talk. We have free access to healthcare for all, and because of this, CT scans are performed primarily in public hospitals. This is particularly the case for children. We also have an NHS central register, which records details of every person in the United Kingdom who is registered to use our NHS general practices. So this means we can obtain cancer, death and emigration information at a national level. We have national and regional cancer registries giving complete coverage of the United Kingdom, and all feed into the central registry. And we have the ability to obtain umbrella consent to make ethics and research governance less of an issue than it is in many other countries. So in the full UK study, our primary objective was to assess the risk of subsequent cancers in individuals exposed to radiation from CT scanning during childhood or as young adults. We also had some secondary aims. The first of these was to evaluate trends in CT usage in young people according to patient and healthcare characteristics. The second was to spearhead collaborative international studies to allow results to be pulled, and with that to increase statistical power, especially when looking at rarer cancer outcomes. The first phase of our study was a cohort study, and that's what I'm going to concentrate on today. To be in our cohort, patients have to have had at least one CT scan between 1985 and the end of 2002. They had to have been under the age of 22 years at the time of their first CT, and be free from cancer at their first CT. The way we found the latter information was mainly by using the cancer registry information to ensure that we did exclude all patients that had had cancer at their first CT, But as you'll see later on in terms of our methodology, we also excluded patients diagnosed within 5 years of their first CT for a solid tumour to add to our exclusion of patients with possible existing cancer symptoms. We obtained our patient and scan information from radiology departments with available electronic radiology information system data of sufficient quality that covered the same time period as our study. We also obtained film and paper records from a small number of hospitals, but this was too time and resource intensive to do for all patients. Our second phase is a nested case control study, in which we're using cases and controls from within the cohort, so all have had at least one CT scan within the right time frame and age group. And we're doing this to assess dose response more precisely by obtaining film parameters so that we can address the uncertainties around our dose estimates. This work is currently in progress, so this is all I'll say about the case control study at this stage. CT scans deliver very non-uniform radiation doses across the body. So in terms of dosimetry for the cohort study, the details we used came mainly from the radiology information system records. We had the date and type of scan, age and sex all available electronically. We then had typical CT machine settings for young people taken from 2 UK-wide surveys in 1989 and 2001, but we didn't just stop there. The dosimetry was done by our colleagues at the National Cancer Institute, and they took these data and combined them with those from hybrid computational phantoms and used Monte Carlo radiation transport techniques to give estimated absorbed organ doses based on integer years of age, sex, time period and type of CT scan. So for our leukemia analyses, we used the red bone marrow dose, and for our brain tumour analyses, we used the brain dose. And we've calculated cumulative doses where patients had more than one scan, but we've also taken into account the timing of when the scans were done within our statistical analyses. For our outcome data, we linked our patient information data with the data held by the NHS Central Registry, and we did our linkage up to 2008, so this gives us cancer incidence, mortality, and loss to follow-ups, including notified emigrations, for example. We excluded patients with existing cancer and those diagnosed with leukemia within 2 years of their first CT and within 5 years for brain tumours, due to the way that children with brain tumours can receive a number of scans over a number of years before they actually have a diagnosis. With this in mind, we also had sensitivity analyses with even greater years of exclusion to really address the issue of whether our findings for brain tumours may be due to patients with existing cancers yet to be diagnosed. The statistical analysis was done primarily by Mark Little of the National Cancer Institute. As is standard within radiation epidemiology research, we used Poisson relative risk models fitted by maximum likelihood methods, but also assessed whether there are any issues regarding linearity within this modelling framework. Accrual of person time began 2 or 5 years after the initial CT scan, depending on whether the analysis was for leukemia or brain tumours. There was also a lag time of 2 or 5 years, and sensitivity analyses again with longer time periods. Moving on to the results, I'll start with some descriptive findings. Our cohort before exclusions was around 245,000 patients. We then excluded those with pre-existing cancer, including those diagnosed within our exclusion periods, and those that couldn't be linked by the NHS Central Registry, and this was mainly due to patients having residence outside of the UK at the time of their scan. This left around 180,000 patients in both the leukemia and brain tumour analyses. The numbers differ slightly due to the different exclusion periods in terms of the number of exclusion years and different lag times used. These 180,000 patients had around 280,000 CT scans. Over 60% of these were of the head, which is consistent with what's been seen in other settings within this age group. This table summarises our findings for leukemia. Overall, we see a significantly increased risk of leukemia with increasing red bone marrow dose. This was based on 74 cases of all types of leukemia, including those with myelodysplastic syndromes. Here we can see the excess relative risk of 0.036 per milligray dose to the red bone marrow. When looking at subtypes, the association was significant for ALL, not significant for AML, significant for myelodysplastic syndromes, and then not significant for leukemia when we excluded the patients with myelodysplastic syndromes. These results can be demonstrated more graphically using this figure, which shows both the fitted model linear relative risk estimate per milligray, as well as some fitted categorical data. Here you can see clearly the increasing risk of leukemia with increasing red bone marrow dose, and also you can see where the relative risk is 3. So the estimated tripling of risk of leukemia coincides with a red bone marrow dose of around 50 mg. As I said before, we did some sensitivity analyses for all of our analyses, and here we have the results for leukemia. If we have a 2-year lag and 2-year exclusions, but restrict the follow-up to 2004, so to have a tighter time frame in terms of follow-up, we again have a significantly increased risk of leukemia, with increasing red bone marrow dose. But in contrast to the previous results, it was now also significant for ALL, and it was also significant for all leukemia, even when the patients with myelodysplastic syndromes are excluded. We also looked at restricting the leukemia cases to those diagnosed under the age of 25 years, and again we see a significant increased risk of leukemia, with increasing red bone marrow dose. Also for leukemia, the dose response did not vary with age at exposure, time since exposure, sex, or any of the other covariates examined, and there was little evidence of nonlinearity on the dose response. Now moving on to our results for brain tumours in relation to brain dose. We have a significantly increased risk of brain tumours with increasing brain dose, as you can see in this table. It was highly significant for all brain tumours, with an excess relative risk of 0.02 per milligram of brain dose. When looking at subtypes, the brain dose from CT was also significantly associated with glioma and a combined group of schwannoma and meningioma. This can again be demonstrated graphically, so here is the figure for brain tumours in relation to brain dose, with again a clear association visible. Again, if we look at the tripling of risk, it is at around 50 to 60 mg of brain dose from CT. So our main findings are that we have significant associations between the estimated radiation doses and the subsequent incidence of leukemia and brain tumours. To get to the tripling of risk of leukemia and brain tumours I mentioned in the figures, using typical current doses, you need about 5 to 10 head CTs for leukemia to get you to around 50 mg to the red bone marrow, and 2 to 3 head CTs will give around 60 mg to the brain. In terms of critical appraisal of our own study, we used empirical data, which is a real push forward in terms of the approaches used in the previous studies in this area. We took a cohort approach, which has avoided recall bias. Our exposure data came from medical records with no patient contact. This was possible using the umbrella consent available in the UK to such studies, and ensures no selection bias based on patient participation. This is in contrast to a few case control studies that have also assessed cancer risks from CT scans on the basis of self-reported history of diagnostic radiograph exposures. These studies might be subject to recall bias, whereby patients diagnosed with cancer are more likely to recall previous medical radiation exposures than are unaffected controls, and also high levels of reporting error. The UK has a free-to-access healthcare system, so this means we should have a representative sample of young people who have had CT scans. We also have nationwide cancer registration, with cancer ascertainment estimated at around 97%. We had an initial cohort of around 245,000 patients, which dropped down to 180,000 when we excluded cancers and patients that couldn't be matched. The majority of those that couldn't be matched were patients residing outside of the United Kingdom and hence couldn't be linked to any of our cancer registry information. For those who couldn't be matched with the registry records, we looked at whether they were different in any way to those that were included. They weren't. They were very similar in terms of the characteristics that we could assess. One obvious question is what our findings might mean in terms of adult exposures. And it's not clear really whether we can extrapolate our findings to those seen in adults, as our results are only based on exposures in childhood or early adulthood. This would require a further study of a similar nature, and is something that we are interested in taking forward. Another question that arises is whether our findings, particularly for brain tumours, are anything to do with pre-existing cancers. I think we've addressed this by using a careful approach to avoid those with existing cancers, particularly with the use of longer exclusion periods for the brain tumour analyses. It's also very unlikely that a patient with leukemia would have a CT scan in relation to their cancer. Our dosimetry was much improved on previous estimates for CT scans in this area and provided organ doses. We estimated doses for each scan that every patient received. However, uncertainties still exist, but we do not currently feel that this would be expected to bias our findings in any direction in particular. We weren't able to obtain individual level parameter data for such a large and historical cohort, but we are trying to address this within the case control study, and to address the potential uncertainties of our dose estimates and how that might impact on our findings. We didn't have any information for the reason for the CT, so we're not able to investigate if certain patient groups at a known increased risk of cancer were included. One such group has been suggested to be patients with Down syndrome. However, from a UK perspective, there is little evidence to suggest that these patients have an increased exposure via CT, and we also had no cases of megakaryoblast leukemia, which is the subtype most strongly related to Down syndrome. In terms of whether our findings are what we would have expected at the outset, well, the easiest comparison to make is with the lifespan study of Japanese atomic bomb survivors, and on this slide shows the comparison for leukemia. Limiting follow-up times to 15 years, the lifespan study had an excess relative risk of 0.045 per millisievert, while we had an excess relative risk of 0.036 per milligray, and with the confidence intervals overlapping. So our findings really do fit in with the previous studies from the lifespan study, but also with the previous modelling and risk projection studies which showed similar findings because they were based on the same data from the atomic bomb survivor data. In terms of how to interpret our findings, I've already said that the tripling of leukemia risk is at 5 to 10 head CTs in children based on a 50 milligray exposure based on current dose estimates. Using our absolute excess relative risk estimates, that corresponds to just one excess case of leukemia in the first decade after the first CT if you have 10,000 head CTs in under 10-year-olds. So we're talking about a very small excess risk here. For brain tumours, only 2 to 3 head CTs are needed to triple the risk. But again, for every 10,000 head CTs in under 10s, you'd expect one excess case of brain tumour in the first decade after the first CT. So again, a very small excess risk. However, there is a caveat with the brain tumours, that brain tumours are more likely to appear later than the first decade after the first scan, whereas if they are very radiation related, whereas for the leukemias you would expect most of them to appear relatively early. The overall conclusions for our study are that the immediate benefits should outweigh the small risks that we've seen when CT is used appropriately. Of utmost importance is that where CT is used, it should only be used where fully justified from a clinical perspective. So thought should be given to see if usage and doses can be reduced further to only fully justified exposures in line with the ALARA principle and the efforts of the Image Gently campaign. It's worth noting here that in the UK, we have ionising radiation medical exposure regulations that mean a CT scan should only be done when clinically justified, and most often this is following national clinical guidelines. This might explain why levels of CT usage in the UK are lower than that seen in other countries that don't have the same regulations. There are similar studies in progress elsewhere, particularly those that are already well underway in Canada and Australia. There's a European Union funded collaborative study called EPICT, which began in 2011. The UK study is included within this, and as part of that study, and having recently received further funding from Cancer Research UK, we're extending our cohort much further with scans up to the end of 2012. So we're including new patients but also new scans in terms of the existing patients in our original cohort. The other countries included within the European collaboration are France, Spain, Germany, Denmark, Sweden, the Netherlands, Belgium, Norway and Luxembourg. I'm also part of a group establishing a similar study in Brazil. All studies are using a similar study design, and collaborations are underway in terms of dosimetry to ensure comparability of findings. In terms of our own future plans with CT, we want to further the risk-based analyses, although this is partly dependent on number of cancer cases for each of the cancer types. We want to look at uncertainties in our dose estimates, primarily using the film and PACS data that we're collecting in the case control phase of the study. We want to pool the cohorts from the different countries for pooled analyses at risk. This will initially be of the cohorts that are already established, but will eventually also include the newer European cohorts and the other cohorts that appear in the coming years. We need long-term follow-up of all these cohorts, and we need to build links with the genetic and epigenetic studies to get a better understanding of the likely mechanisms involved. I'd like to acknowledge the help of my many colleagues who've worked on this study and the radiology departments that gave us their data or access to their films. The names on this slide also demonstrate the range of collaborators required for such a study to be successful. We have epidemiologists, statisticians, computing support, data entry staff, paediatricians, radiologists and medical physicists all involved in the study. This, my final slide, shows the publications from the study so far. These include the initial descriptive papers, a paper on dosimetric methods, and the paper at the bottom, which is the full reference for the study that was published in The Lancet and is available as open access. I'd like to thank you for listening to my talk, and I apologise that I'm not available for the question and answer session, which is due to the time difference between the United States and the United Kingdom. Thank you.